Hey everybody, welcome to Supplementary video 9.1 to 9.6. This is the final video lecture that we have for our skeletal system unit. In this unit, we're going to add a few things talking about joints, as well as take a look at a select few joints. So you can classify joints based on their structure, and there are three types of joints that you get when you look at their structure. You have fibrous joints, which are going to be those joined by fibrous connective tissue. This is going to include joints such as a suture, which is very narrow and is very convoluted to prevent any sort of movement, although unborn babies actually won't have these sutures brought together in a narrow way. They'll have what's known as fontanelles, and that the spaces between those bones are actually what's going to allow their brain case to get pushed together and even those bones to even overlap while they're traveling through the birth canal. Another joint that falls under a fibrous joint is a syndesmosis. These are going to be slightly wider than a suture, but they're going to be held together by a ligament or by some sort of interosseous membrane. You'll remember we have interosseous membranes in between the radius and ulna of the forearm, in between the tibia and the patella of the leg, or the tibia and the fibula of the leg. And then a gomphosis is a narrow joint between a tooth root and the jaw socket, and it's going to be held together by periodontal ligaments. A cartilaginous joint is going to be a joint held together by hyaline or fibrocartilage. It's going to include things like a synchondrosis, where it's going to be using hyaline cartilage. This may be a temporary joint. For example, your epiphyseal plates do contain hyaline cartilage, and they are joining the epiphysis and the diaphysis together. And so that is an example of a temporary synchondrosis joint, but they may be permanent. And then you have your symphysis, which are going to be using fibrocartilage, and they're going to be very, very strong joints because fibrocartilage has lots of collagen fibers within it. And then you have your synovial joints, which are going to have a fluid-filled joint cavity. They may have fibrocartilage in the form of an articular disc or a meniscus, or things like a bursa, a tendon sheath. But all of those are going to be used to unite, cushion, and or reduce the friction that's present in that joint. Some extra joint movements. We'll go over a handful of them in the high school portion of this class. Here's some extras. You have protraction and retraction, which are only going to be joint movements of the scapula and the mandible. Protraction is going to be where you are moving that joint forward. So you're rolling that scapula or rolling that mandible forward. Retraction is going to be pulling them in the posterior direction. So when you have really good posture, you are retracting your shoulder blades. Depression and elevation, another pair that are only seen in the scapula and mandible. Depression is where you're going to move the joint inferiorly. Elevation, you're going to move that joint superiorly. So if I raise my shoulders, that is elevation. If I lower my shoulders, that is depression. Excursion is a mandible only joint movement. This is going to be when you move your jaw side to side here, that side to side motion. Superior and inferior rotation are only seen in the scapula. It's responsible for moving the glenoid cavity either superiorly or inferiorly to keep the acromion out of the way of the greater tubercle as you are moving, as you are raising that arm. It's going to just rotate that scapula. And then you have opposition and reposition. So we can say that humans have opposable thumbs. What it means to be opposable, that opposition movement. We can take the tip of the thumb and we can touch it to the tip of a different finger. And so that is opposition. And then moving that thumb back to anatomical position is reposition. Okay, so now looking at a select few joints here, we'll look at the glenohumeral joint first. This is your shoulder joint. You have some cartilage called the glenoid labrum, which is going to be slightly deepening the glenoid cavity. So it's on that glenoid cavity, and it kind of extends beyond the glenoid cavity a little bit to make it a little bit deeper. You have four rotator cuff muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, all of which are going to be originating at some point on the scapula and then attaching to either the greater or the lesser tubercle of the humerus. While they are moving in that direction, though, their tendons are going to circle around the humeral head, and they're going to help thicken the articular capsule that you have around that shoulder joint. You also have a subacromial bursa and a subscapular bursa, which are going to be responsible for preventing friction between the rotator cuff tendons and your scapula. So we'll look at a picture here to give you an example where we're looking at. Here's your AC joint. Here's the glenohumeral joint here from the glenoid cavity of the scapula, and your humerus, the head of the humerus here. They even include tendon of the biceps brachii muscle as well. But you can see this articular capsule here wrapping around all the way around there. That is our fluid-filled cavity. Here's the glenoid cavity where we're going to be having synovial fluid within there. Here you have your subacromial bursa, so sub meaning below, acromial referring to the acromion of the scapula right there. And then you have your articular cartilage. You have the glenoid labrum here. You can see how it slightly extends and deepens that glenoid cavity. There's your clavicle. And I'm trying to think if that looks like about all of it. Okay. Moving on to the elbow joint. In addition, some things about the elbow joint. You have the ulnar collateral ligament, or the UCL, which is going to run from the medial epicondyle of the humerus to the proximal ulna, and it's going to be responsible for preventing hyperextension of the elbow. That UCL is the ligament that is torn or damaged in some way and gets fixed a lot in your baseball and softball players, especially your baseball pitchers. And that's what's going to be fixed in Tommy John surgery, named after the first Major League Baseball player to receive this surgery, whose name was Tommy John. The radial collateral ligament is going to be on the lateral side. It's going to run from the lateral epicondyle of the humerus to the annular ligament. That annular ligament encircles the head of the radius and keeps it pulled tight. Annular, think like cycle or circle, and that's where it's going to get its name. So here we'll take a look at the lateral view first. You can see that radial collateral ligament running from that lateral epicondyle and that annular ligament, how it's going to be wrapped around the head of the radius. On the medial view, you can see that UCL. There's the annular ligament again, but you can see how it's running from there, and that's what's going to be fixed in Tommy John. Some other things, you do have bursae in your elbow joint. You can see here, this is the humerus kind of cut a little weird here to be able to show this. Here is our coronoid process. Here, this is going to be your ulna. You can see that U shape that's going to be giving rise to the elbow joint. Next up, we'll look at the hip joint. You have three femoral ligaments: the iliofemoral, the pubofemoral, and the ischiofemoral, all of which are going to be spiraling around the head and neck of the femur, and they're going to pull it tightly into the acetabulum during extension because you don't want to hyperextend your hip joint, especially. You want to be able to keep that that head of that femur tightly into the acetabulum and not have a dislocation occur. Reason you don't want a dislocation to occur is you don't want any sort of damage to the ligamentum teres. So the ligamentum teres spans the acetabulum from the femoral head, or from the acetabulum to the femoral head. And while it is a relatively weak ligament, it's very important because it provides a pathway for an artery to enter the femur and actually supply the head of that femur with blood, which is very, very critical. So here you can see a few views here. Here we have the femur, how it's getting up into the acetabulum. You do have a labrum for the acetabular ligament, labrum here. Here you can see that ligament. The ligamentum teres is also known as the ligament of the head of the femur. I think ligamentum teres just sounds a lot cooler. So that's where that sits. You can see those iliofemoral, pubofemoral, as well as the ischiofemoral ligaments are all going to be wrapped around the head and neck of the femur to be able to pull that in tightly. Okay. And then the last joint we'll look at is the knee joint. So you have a medial and lateral menisci, plural of meniscus. They're going to be attached to the tibial condyles and provide padding to the femur and tibia. So that those menisci are going to be preventing any sort of bone-on-bone friction. So it's going to provide a smooth surface for that. The lateral collateral ligament and the medial collateral ligament, your LCL and MCL respectively, are going to be responsible for stabilizing and supporting the knee and preventing any sort of side-to-side motion. You do also have the famous anterior cruciate ligament, the ACL, and a posterior cruciate ligament, which are named based on where they're going to be attaching to the tibia. They're going to be supporting the knee and preventing the femur from slipping off the tibia, especially at PCL. You think when you're trying to walk downhill, you don't want your femur to slip off your tibia in the anterior direction, and that's what the posterior cruciate ligament is going to be preventing. So here, this top right picture, you can see a picture of the menisci, how they have that C shape, which is what meniscus translates to as C shape, and they're going to be sitting on top of that tibia and preventing any sort of friction within there. Take a look over here. We'll start here. You can see that lateral collateral ligament and the medial collateral ligament here. They're also named for the bones that they're attached to. So you have the fibular collateral ligament, which is also known as the LCL, and the tibial collateral ligament, which is your MCL. And you get in here, you can see the anterior cruciate ligament is going to attach on the anterior side, and then your posterior cruciate ligament is going to be attaching on the posterior side. Okay. So those are take a look at some of the extra things to know about joints, as well as the anatomy of a select number of joints, taking a look at the glenohumeral, the elbow, the hip, and the knee joints as well. Again, this is the last video lecture for the skeletal system, so making sure you're keeping yourself caught up on each of these video lectures, making sure you're finishing your modules, and then don't forget, once you have these complete, to be able to prepare yourself, get yourself ready, and when you are ready, take that Unit 3 test.